Very good evening to all the doctors who have tuned in today. On behalf of Health and You, it is my pleasure to welcome you to this webinar. This webinar is titled RELOOK. At Migraine Preventive Treatment. This webinar comes to you on behalf of Health and You, a digital initiative as DigiNeuro. Health and You is a joint venture with Newlink Company Limited, Japan. We have innovative products first time in India. Health and You was first to offer you Brentamin, vitamin therapy for migraine, riboflavin 200 mg, magnesium 200 mg, and CoQ10 10 mg. You can prescribe Brentamin as a co-prescription with conventional anti-migraine therapy to increase the success of conventional anti-migraine therapy. You can prescribe in childhood and adolescent migraine when one cannot give conventional migraine therapy which can interfere with his learning, and in migraine during pregnancy when any other anti-migraine therapy cannot be given. One tablet BID. We also launched first time in India amitriptyline plus mycophenolate combination Amnurite 5, 10 and 25. In fact, amitriptyline 5 mg was given first time along with Amnurite for neuropathic pain and for migraine. And when migraine is not controlled by one, in migraine with comorbid condition, one can prescribe AmnuriteBeta. First time in India, combination of amitriptyline and propranolol, AmnuriteBeta 520 ER and AmnuriteBeta 1040 ER. Our innovation continues. All these that you are seeing, current webinar and the earlier webinars are available on DigiNeuro YouTube channel. So you have to just go to YouTube and type DigiNeuro and you will get a huge resource of neurology and neurosurgery topics on this channel. Today I have great pleasure in introducing our moderator, Dr. Soumyadarshan Nayak. He is MD DM Neurology. He is currently Assistant Professor in the Department of Neurology, SCB Medical College, Cuttack. Sir has taken his fellowship in headache from IHS Sydney, Australia. Sir has been awarded as the most inspiring neurologist by Economic Times in 2019. Sir has been chairperson and speaker in various association programs, conferences and seminars of neurology. I have great pleasure in handing over the session to Dr. Soumyadarshan Nayak. Thank you very much.
Thank you, Deepak, and a very good evening to all our viewers. And it's my pleasure and honor to introduce none other than Dr. Ravishankar, who has been a mentor, guide, and one of the pioneers of headache medicine in India and world over. Just a few words, it would be like a drop in the ocean for Sir. His journey in headache medicine started from one of the best headache clinics in the world, that's the Houston Headache Clinic, Texas, US, and the City of London Migraine Clinic. And since the 80s, Sir has been the pioneer of headache medicine in India and even world over. His journey has been one which is not less than a potboiler. Sir has been on the board of trustees of the International Headache Society. He has been honored with a lifetime membership of the IHS and has received special recognition awards at Boston in 2013. He's in the editorial boards of Headache Current and a reviewer for one of the best magazines of headache, Cephalagia, and also Headache. He has a lot of scientific publications to his name and an ardent speaker, not to mention that full conferences go on in Sir's name, and it was way back in 2013 when we went to attend the IonCon at Chandigarh. Then Most of the doctors whom I asked, they had come to attend Sir's lecture, and it was not only a pleasure, a treat to watch. An humble person and a very friendly person. His motto is that you have to start treating headache disorders just to experience the joy which a patient gives, the joy or the satisfaction of riding a headache sufferer of his pain, which is something which we have to experience. And all these chronic long-term care should always be given to those who believe in managing headache, and they have the need and they have the necessity to treat these headache disorders not only at from their heart. And Sir's talks always touch a chord in everyone's heart. So I leave the stage to Sir Dr. Ravishankar, who will be talking on migraine therapeutics, a RELOOK. So over to you, sir.
Good evening, everybody. Thank you, Mr. Deepak, and thank you, Dr. Soumyadarshan, for the kind introduction. I don't know if I'm deserving of all that you have told in your introduction, but I will now have to do justice to whatever you have said. So, and let me try and see how best I can manage it. I'm going to share my screen now. Right, I hope all of you can see my screen.
Yes, sir.
Yes. Now, migraine, as you all know, is one of the commonest problems that we see in practice. But for whatever the reason, whether it is lack of teaching in the undergraduate school, whether it is lack of interest, or whether it is lack of focus, migraine still continues to be under-recognized, underdiagnosed, and undertreated. That does not mean there have not been many advances in this field in the last few years. But unfortunately, the fallout of all these advances have really not percolated into practice for the benefit of our patients. And we still see that there is a huge gap between the theory and practice of migraine. So what I'm going to do in the next 40 minutes is to try and fall back on my experience and evolve for you a plan of approach to the preventive treatment of migraine. I'm fully aware that headache is only one part of your practice, so I will keep it practical. I will keep it simple, and with a few take-home messages. I will list the traps that we see in practice, and I will also give you some tips which will make it easier and help you improve the outcome in your difficult migraine patients. So what is going to be the plan of my talk? How am I going to roll this out? I will first give you an overview of migraine. I will talk about the burden and the expanding spectrum of migraine as it is today. Then I'll talk about the unmet needs in the preventive treatment of migraine. We will then talk about the basic principles and the paradigms of preventive treatment. When do we start? Why do we give? What are the goals? Then talk about what is necessary to be done, the current options, the pharmacological options, and then spend some time on talking about what is not being done, the alternative treatments, and the important role of nutraceuticals. And finally, I will conclude by telling you what is in the future and what do we ideally need for the optimum preventive treatment of migraine. So this is the logo from July 2019 on World Brain Day, which was dedicated to raising awareness for migraine. They called it the painful truth. And the webinar was to raise the burden and awareness of it, to emphasize on the burden and raise the awareness for migraine. And the speakers on that occasion, it was a combined event of the World Federation of Neurology and the International Headache Society. And the speakers on that occasion were all heavyweights. Professor Bill Carroll, the president of the WFN, Professor Edwinson, who gave us CGRP, and Professor David Dodick. So what was the message they were trying to convey? The message that they were trying to convey was that migraine is a very common and a legitimate neurological disorder. I use the word legitimate because there's nothing any longer psychological about migraine. It's all biology. It's well-proven biology. And it is the second most disabling disorder when you look at the years lived with disability. This is from the WHO. And it affects people across all ages, races, socioeconomic class. There's a very high prevalence, about 18% in females and 6% in males. And most importantly, it affects during the peak productive years of a person's lifetime between 25 and 55. And if you look at the cost, economic burden, it's almost 27 billion in the US where it's measurable for both episodic migraine and chronic migraine. So it's very appropriate that in this, the Migraine Week, we are conducting this webinar on a most useful topic, the preventive treatment of migraine. Now let us look at the entire spectrum that is migraine as it is in the ICSD-3, the third classification, released in 2018. There have been 2 earlier classifications. And you will find here that a number of terminologies have changed. A number of new items have been added, subtypes have been added. And if you look at migraine with aura, there are 4 clear subtypes. Basilar migraine is now called migraine with brainstem aura. Chronic migraine has been given a separate rubric of 1.3. The complications of migraine have been listed. And there is a new entity which is included called probable migraine, because there are quite often, when you see in practice, you may not be having all the criteria being fulfilled, and that is when you call it probable migraine. And then what you see in children are the episodic syndromes that later on go on to become full-blown migraine. Now, it's important to know this spectrum because when you choose preventive drugs, there are different drugs which you will choose based on the type of headache you're dealing with. For example, in hemiplegic migraine, you might go for calcium channel blockers, which will work better. When you have migraine with aura, which is a prolonged aura, you might opt for levetiracetam. And so therefore, it is important to not only diagnose migraine, but also to try and see if you can subtype the type of migraine that you're dealing with. Now, while we are talking of migraine, what we need to know, we need to conceptualize migraine correctly. And why have I called it a locked-in state-like syndrome? Because quite often in practice, what I see is that a lot of doctors treat migraine from attack to attack. They do not look at migraine as a long-term disorder. They do not treat in a way to reduce the frequency, reduce the severity, and improve the future life of the migraine. Because it is a genetically inherited disorder, your genes don't change, because it is worsened by triggers from the environment, which also does not change, and because the drugs that we have today are not still the perfect drugs which can take care of migraine 100%, and because some migraines progress, some migraines are recurrent, and some migraines persist, we need to look at migraine not as an episodic disorder only. We need to look at it as a chronic disorder with episodic attacks that can keep on changing throughout the lifetime. This is where preventive treatment is so important. In fact, I always explain this to all the patients because it is genetic. Once a migrainer, always a migrainer. The suffering need not be the same throughout life, but the tendency remains. So please bear this in mind that you need to treat all patients who have frequent migraines with both preventive treatment as well as acute treatment. And because of comorbidities that are more commonly seen in migraine, you have a lot of disability, and because of risk factors, you have episodic migraine quite frequently going on to develop chronic migraine in a significant number of patients. In fact, almost 60 to 70% of patients who see us at the tertiary headache clinic are for chronic migraine. The episodic migraines most often go to the general practitioner. Now, against this backdrop, how do you plan out the treatment? You have to first understand that no two migraineurs are similar. So there is no standard treatment that you will give for all migraineurs. This is a very important point to remember. You can treat all asthmatic patients with the same medicine. You can treat all diabetics with the same medicines. In fact, you can even treat cluster headache with the same drugs. But you just cannot treat migraine with the same drugs for every patient. So it's important to individualize and customize the treatment. This is a take-home message. For that, you need to first establish a good rapport with the patient. The patient should get the feel during the history taking that here is a doctor who is interested in getting me better. That's what is called a rapport. And the three pillars of any treatment of migraine is first to control the triggers, to institute lifestyle measures, to give a satisfying acute treatment for the patient, acute treatment that works, and to choose the best preventive option, both pharmacological and non-pharmacological. And if need be, if the patient is refractory and has already tried out a lot of these, to look at future treatments that will benefit the patient. A good synergy, a good combination of all these three pillars is what is going to improve the outcome in your migraine patient. Now, I have titled the talk, the word RELOOK has been used, and so we need to know, why do we need to revisit this area? Is it not a given? Is it so complicated? Is it that difficult? These are some points which I have put together from what I've seen in practice. And I am also guilty of missing out on many of these points when I have to see a lot of patients. But if you make this a routine practice, then you will see that you don't miss many of these areas. First of all, you need to spend time and focus on what sort of preventive plan you are going to give that patient. It has to be comprehensive. You have to explain to the patient, why are you choosing preventive treatment? Why daily medicines for migraine? The goals. You have to set the right expectations. There is no 100% in the field of migraine anywhere in the world. So you have to set an expectation of 50, 60, 70%. And this most often not addressed point, the duration for which you're going to use the prophylactics. So please don't allow your patients to go away with the thought that this is a course of 2 months or 3 months. Migraine preventive treatment is never a course. It's for as long as the patient needs it. Then talk to him about lifestyle measures, doing the same thing at the same time every day. choose a good, specific, satisfying treatment option, and follow the principles of preventive treatment, which we are going to talk about, the paradigms, and stratify your treatment. There have been many debates on whether monotherapy or polytherapy. That could be so for epilepsy. That could be also for other disorders. But when it comes to migraine, monotherapy always does not work in many patients. It depends on the migraine threshold. So therefore, if the frequency and severity demand that you add more drugs, so be it. So there's no question of going just with propranolol and flunarizine for all patients of migraine. It won't work. Patients seen in tertiary care do often need more than one drug. And it's never the same drug. There's something called pharmacogenomics. So when you wonder why your patient is not responding to propranolol, not responding to flunarizine, the first line which you have tried, you have to change the drug because it's not the same drug which works in all patients. And it's a process of trial and error. Even after so many years of seeing so many headache migraine patients, we still don't get it right the first time. So this is also to be conveyed to the patient that there is a process of trial and error. So you do not get it right the first time. There has to be a follow. You have to readjust the doses. You have to look for adverse effects. You have to give an adequate trial of every drug at least 1 to 2 months. You have to ensure compliance. You have to make sure patients adhere to what you're telling them. You have to look for comorbidities. You have to look and see whether you need to eliminate any risk factors which could lead to progression from episodic to chronic migraine. Are there any coexisting illnesses which could be contraindications for the drugs which I am using? Are there 2 drugs which I can combine? Can I treat 2 conditions, the migraine and the comorbidity, with 1 drug? So look for therapeutic opportunities, limitations, and based on different mechanisms of action, can I combine 2 drugs to achieve more? These are the thoughts which will go on in your mind. What is the patient profile? What does he want? Does he want drug treatment? Does he prefer alternative treatment? There are many patients who fear side effects. What is the most bothersome symptom? What is the most feared symptom? Many of them have severe nausea. That bothers them more than the head pain. And what is the profile? Do I use different drugs? For menstrual migraine, you will treat differently. Does the patient have refractory migraine? Is it vestibular migraine? And other special situations that need to be tackled. Children have different drugs which work as preventives. In pregnancy, very few drugs are allowable as preventive. The elderly have medical disorders which are contraindications. And when treatment fails, you've got to analyze the reasons why treatment fails. And you need to be aware that when a patient has medication overuse headache because of overuse of analgesics which contain caffeine, codeine, or too much of ergotamine, or too much of triptans, the prophylactic drugs which you're using will not work. And you wonder why. When you're increasing the dosage, why is the drug not working? And then when you really get stuck and you think the patient is refractory, always think of a colleague from whom you can take help. You think it over and see whether the patient needs referral to a psychiatrist, whether there's comorbid depression, comorbid anxiety. And finally, if the patient is affording and can get some drugs from abroad, look at the possibility. As of now, we don't get anti-CGRP monoclonal antibodies in India. So look at the possibility of telling the patient to source the drug from abroad. And finally, in spite of doing all this, you still have 5 to 10% who just don't respond, do what you may. There you need to think of devices. And finally, you have to understand that the goalpost keeps changing in the field of migraine. So preventive treatment is a dynamic process. And lastly, everything that I've told you is based on empathy. You got to literally feel the patient's disability. You got to understand how that migraine is impacting his routine life, his ambitions, his family life, and how it is making, it's an invisible misery. So you got to have that empathy towards the patient. If you do all this, then I'm sure your patient is definitely going to improve faster. So looking at the paradigms. Now, when do you use preventives? When the attack frequency is more than 1 per week or 4 per month, when the migraine interferes with routine activities of the patient, when you think he's using too much of analgesics, when you think that acute medicines are not working too well and they are contraindicated for whatever reasons of heart disease, hypertension, and they are being overused, and if the patient prefers it, for example, if a patient has a severe attack of hemiplegic migraine or brainstem migraine, he may not tell you. I mean, you don't need to wait for 4 per week, 4 per month. You could take it even 1 attack per month. You would still want to prevent that because this is a major debilitating attack. So therefore, you'll have to take the call with certain uncommon subtypes of migraine that regardless of the above rule, I am still going to go ahead with preventive. Because if he's getting a ptosis due to an attack of ophthalmoplegic migraine, you would not wait to say that it should be 4 attacks a month as per the rules. So please understand that patient preference is also important. What do we try and achieve through this preventive treatment? What do we want to get? We want to reduce the attack frequency by at least 50%. We want to improve the responsiveness to acute treatment. A lot of times patients who are not on preventives or who have dropped out because of compliance problems, they come and tell you that the acute drug was working well when I was on the daily medicines, but now the acute drugs, the same drug does not seem to work. And that is because of the responsiveness to acute treatment. That can be improved with preventive treatment. You can improve the function, and you'll have to try and reduce the disability, improve the quality of life. And with preventive treatment, you will prevent disease progression and reduce the chances of medication overuse headache. Now, what with these being the indications, these being the goals, what really happens in practice? This is from the American Migraine Prevalence Study. 19,000 migraine sufferers were evaluated. And out of them, 40% at least, based on the above guidelines and principles, needed prevention. But in reality, only 13% were taking prevention. So even at the outset, you are finding that very few people are taking prevention, which is advised to them. And at the end of 1 year, what happens? 83% of people with migraine discontinue preventive treatment over 1 year. So only 17% are taking preventives because they didn't think it was working too well, poor efficacy. They felt that the initial effect is no longer there, and they had a fear of side effects. So these are thoughts which go on in the patient's mind. That is where the alternative treatments, the nutraceuticals, come into play, because we are exploiting the potential of the additional drugs. So therefore, we'll have to combine them along with the routine pharmacology. And you will find that compliance improves, adherence improves when patients are not worried, not scared of side effects. So what are the paradigms you will follow? As I told you, you will first build a rapport. You will explain to the patient. You will look at the frequency. You will look at the disability. You will look for comorbidities. You will look for risk factors. You will study the headache subtype. You will look at the patient profile. Is it a young student who has an exam coming up? He wants the migraine to be out of the way while he's preparing for the exam. Is it somebody who is going to get married? Is it somebody who is going to have some serious change in his life, going to a place from comfort to discomfort? Are there any contraindications, side effects? And you have to personalize based on all the above factors. You have to literally strategize preventive treatment. Use both, combine it with pharmacological and alternative treatments. So what is it that you will explain to the patient? You will explain that he can expect 50 to 60%. Never allow a patient to leave your clinic thinking that he is going to be cured. The word cure does not exist in migraine. The word course does not exist in migraine. So therefore, it is control all the way. And from his present position, 50 to 60% is good enough. Second, there is a natural design of migraine in most patients. It is linked to female hormones. It starts young. It comes down with age. But it's a window of 20, 25 years when the patient comes to you at the age of 20, 25. So do not let the patient get away with a mindset that it's a 3-month course. This is absolutely detrimental to the preventive treatment of migraine. The third, do not let the patient get away with the thinking that my neighbor's migraine got better with just one tablet daily. Why are you giving me 3 tablets to be taken? He is on monotherapy, you're on polytherapy, because the frequency, severity, and the type of migraine you have warrants that. So it is the load with which the patient enters your clinic that decides the level of treatment which you decide for the patient. And finally, reassure the patient that we are also looking at reducing your daily background preventives based on the way your headache comes down. So if your headache comes down due to your good behavior of lifestyle control and trigger control, there is no reason why we should be using more medicines than necessary for any patient. Why on earth would any doctor want to give more drugs to any patient than what that patient's medical condition warrants? This is a very important question. You need to tell the patient to ask and try and answer this question. So therefore, all these things, if they are explained, they go a long way to compliance, ensuring compliance. So now, when do you choose the drug? What's the first question you would ask? What is the frequency? And in frequency, patients tend to tell you only the major attacks. They don't tell you the minor days with headache. So therefore, days with minor headache. So therefore, best way to ask is, how many crystal clear days per month do you have when there are no headaches at all? So he might say, I have 5 days when there are no headaches, which makes it significant. That is chronic migraine most often. Then you assess the disability using questionnaires, and then you go for telling the educated patient to fill up the calendar. So when he fills a calendar like this, it's easy for you to distinguish between episodic migraine and chronic migraine. Here you have a calendar for 3 months, and there are more than 15 days per month when the patient has headache, out of which at least 8 days are migraine, or the patient has been treated with a specific anti-migraine drug. So that fits into the definition of chronic migraine. And so therefore, you know what you're dealing with on the left is episodic migraine, just 3 bad migraine days per month. On the right, you're dealing with chronic migraine. And so you have to decide on the level of medication accordingly. Now, the comorbidities which you need to keep in mind, migraine is quite often comorbid with psychiatric disorders like anxiety, depression, bipolar disorders. Somatization does happen quite often. Migraine is comorbid with epilepsy, stroke, and the rest are rare cardiovascular disorders and fibromyalgia and other musculoskeletal disorders. And while assessing for comorbidities, also inquire about coexisting illnesses, and also inquire to see if there are any modifiable risk factors. Like, for example, a patient might be having a high-frequency migraine, an overuse of caffeine, a lot of stress in his life, a habit of snoring, rule out obstructive sleep apnea, and always evaluate for depression. So once you have this at the back of your mind, then you're going to look at what is the patient profile, because these are facets which help you decide on the drug you're going to choose. Is the patient obese? Is the patient medium, thin? Because obese patients, you can choose a drug like topiramate. You don't want to go with a drug which can put on weight like divalproex. So it's important to know the body structure. It's important to know the urgency with which the patient desires treatment, in which case you might not have the time for trial and error. It's important to determine the burden, the impact, and what is the desired option for the patient. Does he want pharmacological or non-pharmacological? Is better to clarify at the outset. And in that case, you can go for nutraceuticals, you can go for non-pharmacological treatment. And in the future, when it's available, you can go for devices. Right now, we do still have devices like the Cephalagia which are available, but the other devices which are also useful are still not available. And always look at what is the occupation, what is his lifestyle like, when does he sleep, when does he get up, what is the occupation. For example, if you think of starting topiramate and the patient at the end of the consultation tells you, but doctor, I am a pilot and I have to fly a plane, I don't think you should be starting him on topiramate. The same goes for an investment banker who has to make quick calculations. You cannot have a drug which could have cognitive effects. So therefore, knowing the occupation is very important. Knowing the habits is very important. And finally, you will have to also see if the patient can afford the drug which you're choosing for the patient. Cost is also an important assessment factor. Now, the headache profile, the subtypes, you have to evaluate for the subtype and see if he's in chronic migraine. And if there are uncommon forms, menstrual migraine will need perimenstrual prophylaxis. Vestibular migraine would also do well with calcium channel blockers. In children, you would go with ciproheptadine. In the elderly, you would take care when you use amitriptyline. Pregnancy, you would go only with beta blockers. You would not use divalproex. You would not use topiramate. And look for overlap syndromes. Sometimes migraine can overlap with another condition, another of the TACs, the trigeminal autonomic cephalalgias, which might be responsive to indomethacin, in which case you will combine with the migraine drug indomethacin in order to get the patient better. So therefore, the headache profile is very important. Based on all this that I've told you, you will go on to choose your pharmacotherapy. There are guidelines, the American Academy guidelines, the American Academy of Neurology, the Canadian Headache Society guidelines, the guidelines of the European Federation of Neurological Sciences. These are all guidelines which have been laid out, and you choose, and the most common one with which we go ahead is the American Headache Society guidelines. And they have drugs which have established efficacy, drugs which are probably effective, and drugs which are possibly effective. These keep changing from trial based on the number of trials and the evidence that you keep getting. But for practical, in practice, it is better to make yourself familiar with a few of these drugs. If you look at the list, there could be more than 100 drugs which have been tried out in migraine, but it's best to be familiar with the beta blockers, the anticonvulsants, then amitriptyline, the SSRIs and the SNRIs. For us, we have a very useful drug which is not available in the US, that is flunarizine. It's available in Europe. So therefore, you'll find a lot of European studies coming up with the benefits of flunarizine. It can be a first-line drug along with propranolol. Then you have candesartan, which has very few side effects. And when you choose and get familiar with these, you got to adapt based on the patient profile, the contraindications, the side effects, and the cost. So these 4 factors for all these drugs will help you. And the contraindications, when you take the history, for beta blockers, you got to make sure the patient does not have any breathing problem, no asthma, no diabetes, peripheral vascular disease of bradycardia, and for a lot of drugs, hypertension, ischemic heart disease. And when you use divalproex, you always need to be careful that there is no PCOS or PCOD problem. Always ask every patient when you start preventive drugs, their plan for pregnancy. Are their periods regular now? Are they planning to conceive? Is there any history of depression? Is there any renal calculus topiramate? Check, ask for the possibility, keep in mind the possibility of glaucoma and the need for alertness in the job. And when you are starting the patient on the drugs, then you have to be aware in the follow-up, when you see the patient, whether they have developed any of these side effects. For the beta blockers, they could have a lot of fatigue, a lot of weight gain, sometimes depression, dizziness, erectile dysfunction in males. Young males, do not start them on beta blockers. With divalproex, weight gain is always a factor, and they could be having some hair loss. With topiramate, you know about it. They could have tingling, numbness, cognitive problems. Watch for glaucoma. And with flunarizine, be careful, sedation, depression, and the long-term extrapyramidal features. So these are some things which you need to keep in mind. Now, once you've chosen the drug, then what do you go? How do you go next? You start in a small dose. You increase the dose gradually. You have to give an adequate trial at an appropriate dosage. You have to evaluate therapy periodically. You can always go back and forth, but you got to evaluate. And you got to know if you have to combine, and always understand that it is a process of change. And sometimes when you combine 2 drugs, you get more. For example, if a migrainer has hypertension, You can combine two drugs which are anti-migraine prophylactics and which also help in treating hypertension. Migraine with depression, you can use amitriptyline, nortriptyline, SSRIs. Migraine with insomnia, amitriptyline will help you. And obesity, topiramate is the drug of choice which you would go with, provided there are no contraindications. And when people fail more than two of the currently available preventive drugs and also the alternative treatments, then you are in a position where you have to look for the not as yet available anti-CGRP monoclonal antibodies. So the present drugs which we have, what are the unmet needs? The current prophylactics, the pharmacological products, they are all borrowed from other areas, except for the anti-CGRP monoclonal antibodies. None of them are specific for migraine. You have antihypertensives, you have antidepressants, you have anti-epileptics, but the anti-CGRP monoclonal antibodies, which are still to come, are the first drugs which are specific preventives for migraine. And when you have these drugs from other areas, there are safety and tolerability issues. The onset is very slow. They need a little titration to reach the maximum correct dosage. And they do not work in all patients. All drugs do not work in all patients. There's an element of pharmacogenomics. So there are a lot of still everything that you desire in a prophylactic is still not available to us. So we are looking at 50% improvement in 50% of patients. That's the target we tell our patients. That's maximum that we can achieve as of today. So how do you try and how do you optimize the treatment of migraine? So one of the big options which is underutilized are the alternative treatments for headache. And these alternative treatments are being more accepted by patients now. And the alternative treatments, doctors generally stay away from it. Why? Because they may not be aware, they may not be familiar. And the second reason is that they do not have the strong evidence base as the pharmacological drugs. And so therefore the clinical trials, the number of trials are all not as many as with the pharmacological drugs. So therefore people try and stay away, and they are being practiced by other practitioners of alternative therapies. So therefore, the patients do not get the full benefit of all these being combined with the conventional treatment. Now, what is the meaning of alternative treatment? Now, these are all for headache. So let us first understand the terminologies. What we're doing now is the conventional treatment. That's the allopathic medicine, that's the Western medicine, or what is the mainstream, what we've all learned in medical college. Now, what is complementary treatment? Complementary treatment is anything additional that is used along with conventional treatment. As against that, you have the word alternative treatment. What is alternative treatment? That which is used instead of conventional treatment. So there is a difference between complementary treatment and alternative treatment. Complementary is used along with conventional. Alternative is used instead of conventional. And when you integrate all this and try to give maximum benefit to the patient, it is called complementary and alternative medicine, or the short form, which is CAM. So CAM is the usage of a group of therapies which help in giving additional benefit to the patients without adding to the side effects of the patient through the pharmacological drugs. So this is a reasonable understanding of the terminology. Now, if you have to look at what are the, now we'll use the word CAM to talk about integrative treatment. Now, what are the modalities which come under the heading, which are included under the heading of CAM? First and foremost, the most important are the nutraceuticals. And what are these nutraceuticals? The well-tried, the well-tested are magnesium, riboflavin, CoQ10, to some extent lipoic acid. The less well-tested are butterbur or petacitis and feverfew. And what is now hitting the headlines every day on the television, the recreational drugs. marijuana, LSD, psilocybin. These are useful for cluster headache. They are not so useful for migraine, but they are more useful for cluster headache. Now add to this what we call the non-pharmacological treatment or the biobehavioral therapy. You have biofeedback therapy, you have relaxation training, you have cognitive behavioral therapy, and then you have physical therapy. So these are there are practitioners who specialize in these areas, and this is an add-on. This by and large cannot completely replace, although patients might tend to swear by it, acupuncture, chiropractors, oxygen therapy. These are in addition. And then you have complete medical systems, which we may not be aware of as practitioners of allopathic medicine, but there is some value in patients who go in for homeopathic treatment, Ayurvedic treatment, naturopathy, and which we don't have too much in our country, the traditional Chinese medicine. This has been added to complete the slides. So this is all that is additional for the headache patient, and the patients can get benefit out of this. Now, when does a patient go for CAM, the alternative treatment? When the patients choose to go for, by choice, he does not want pharmacotherapeutic drugs. He has experienced poor drug tolerance, when there are certain contraindications for the drugs, when he feels that the response is insufficient, and in some cases, the non-pharmacological treatment such as biofeedback, the physical therapies can all be used in pregnancy. And when there is an excessive need for analgesics, one does go for alternative treatments. And in this study, which was conducted by Wells et al., they found that sometimes when conventional treatment was too expensive, the alternative treatments were cheaper. And when conventional treatment was ineffective, and when he was convinced by family and friends to give up the allopathic treatment or the conventional treatment and go for the alternative treatments. So these are all reasons why patients prefer to go for alternative treatments. Now, what are the alternative treatments that are easy to obtain, that are good to use, that are safe to use, and that are efficacious? The main three are magnesium, riboflavin, and coenzyme Q10. And now we have a combination of this also, combining all three, magnesium, riboflavin, and coenzyme Q10 in the same capsule. So how does magnesium work? What does it do? Now, magnesium, as we all know, has a lot of subtle functions in the human body. As far as it's concerned with headache, magnesium is the mechanism of action. Low magnesium levels can trigger off cortical spreading depression, can release neurotransmitters like substance P. It can aggravate the aggregation of platelets, and the concentration of magnesium influences serotonin receptors, nitric oxide synthesis, and inflammatory mediators. It, in short, controls the vascular tone via the NMDA receptors, which are involved in nociception. And if you look at the magnesium concentration, most of it is in the bones. A lot of it is intracellular, and a very small amount is extracellular, out of which it's the ionized magnesium, which truly reflects the disturbance. And there have been a number of studies conducted with magnesium. One of the foremost authorities in the world on magnesium therapy for migraine is Alexander Moscow. And he conducted a pilot study in 1995. When he studied 40 patients, he estimated the migraine concentration, and he gave them intravenous magnesium. It is safe even to use acutely. 1 gram of magnesium sulfate given intravenously can help in the treatment of status migrainosus, sometimes in acute cluster headaches also. And he found that the patient significantly improved. And the way he suggested that we need to estimate the magnesium is to do an RBC magnesium assay, probably a research tool. And magnesium commonly helps much more when I talked of headache subtypes and selective drug choices. Menstrual migraine is one area. Menstrually related migraine, pure menstrual migraine is one area where magnesium helps. It helps in pediatric migraine significantly because in pediatrics, you don't want to use big drugs. Quite often, the parents object to the use of anti-epileptic drugs for the treatment of migraine in small children. That's a place where magnesium helps. And what happens if you overdose the patient? The dose that you would be expected to use is 400 milligrams per day. And it is commonly used in the form of magnesium oxide, magnesium citrate, and it can induce diarrhea. So you need to reduce the dosage if the patient has diarrhea. And it is contraindicated in kidney disease, or when you look at signs and features of magnesium toxicity. And there have been other studies. So this is evidence base for this is quite significant. And it is also useful in migraine with aura. Now, after magnesium, the next best thing to happen for migraine is a safe drug, a safe vitamin like riboflavin. And it is a cofactor in the Krebs cycle. It has a vital role in membrane stability. It has been tested, and the article was published in Neurology in 2009, where they gave riboflavin and a dose of 400 milligrams for 3 months, and they found a significant reduction in almost 60% of their patients. So therefore, this is again well proven, and the side effects, if you exceed the dose, is again diarrhea and excess urination. Coenzyme Q10, which is now available very easily and useful in most disorders, works through the mitochondrial function. It works as an antioxidant, and there have been enough trials using coenzyme for the preventive treatment of migraine. And again, it is very safe to be used in pediatric migraine. So we have these 3 agents which are very useful as alternative treatments for migraine, and the ones which have less evidence and which have the possibility of some side effects, either through the liver enzymes being raised or through some other contraindications, are some of these, and these are less often used, but it is necessary to complete the lecture comprehensively. So therefore, I have listed them here. And the behavioral therapies which you would use, the non-pharmacological ones, are biofeedback, relaxation training, and cognitive behavioral therapy. And the physical therapies are acupuncture. You can go in for chiropractors. You can go in for transcutaneous electrical nerve stimulation. Sometimes massage helps. Sometimes oxygen therapy helps, particularly when you have autonomic features associated with severe migraine. And the other medical systems which will definitely help, in addition to all the nutraceuticals that you're going to be giving, is yoga. And Ayurveda has some treatment for migraine. Homeopathic drugs are there. And naturopathic agents are also there, which I have not listed here, which help, herbs which help in the treatment of migraine. So if you want to summarize, when you look at preventive treatment of migraine, the first step which you will go is pharmacological options based on whether it's episodic migraine or chronic migraine. You will combine it with nutraceuticals. And if it is chronic migraine, you could try, if the patient is willing, monobotulinum toxin A. And along with this, if the patient has access to a good practitioner of non-pharmacological treatment, and if there is a comorbid depression, anxiety, use of a psychological counseling, if that fails, go on to step 2. This is the anti-CGRP monoclonal antibodies. And if that fails, then go on to step 3, which is use the devices in addition to step 1 and step 2. So this is called layering preventive options in migraine. And when you look at the anti-CGRP antibodies, this is futuristic. So let me just have 1 or 2 slides on this for you to know. So what I talked about so far was necessary to know. What I'm going to talk to you now is good to know. These are, because some of your patients might come and ask you about these agents. So it's better to know that we now have anti-CGRP monoclonal antibodies. They inhibit the function of the CGRP ligand, which is elevated in migraine, or they work at the CGRP receptors, and they are only for prevention. and they are well tolerated, once monthly injections, minimal side effects, sustained efficacy for over a month. There are 4 of them available. We will not go into the intricacies of each one of them, as that is outside the range of this topic. And so therefore you need to know that there are 4 different monoclonal antibodies available. They can be administered by the patient on his own. The first of this, which is going to be launched, is Erenumab, and that's Aimovig is the trade name. And this is how the auto injector is there. The patient just keeps it and injects himself. It's a self-administered injection. And if suppose the patient doesn't want that too, and you want to go in for the devices, what are the mechanical devices which are available, which work through electrical currents or through magnetic fields? The transcranial magnetic stimulation, the supraorbital nerve stimulation called Cephalagia. This is available in India. The vagal nerve stimulation, which is still not available. And then when you have to use invasive options, then you can go in for an occipital nerve block. These are all for refractory cases, refractory situations. And occipital nerve stimulators and sphenopalatine ganglion stimulation will also help. Therefore, ideally, in conclusion, when we want a preventive treatment for migraine, we are looking for proven efficacy. We are looking at improving the quality of life. We want something which will have few adverse effects. We want something where the patient will be adherent to and which need not be given very frequently, easy to administer. It has to work where others fail. It has to be cost effective. And so the best way I would think would be to have a safe pharmacotherapeutic option which you are monitoring, where you're titrating with minimal side effects in that patient. Combine it with an alternative treatment, a nutraceutical definitely. And since you have now a combination drug which has all the 3 important nutraceuticals, magnesium, riboflavin, and coenzyme Q10, and along with that, some amount of non-pharmacological treatment in the form of yoga, and then you would have done your best in trying to control that patient. So therefore, let me conclude by saying that migraine management is sometimes easy, sometimes can be difficult. It is all about the art of conveying the science. And as they say, patients respond to physicians who respond. That means you have to be kind and empathetic to your patient. You will find that you get better results. Thank you.
Thank you, sir, for this enlightening, lucid presentation and touching so many practical points. I think our doctors will now be enlightened to the needs of the patient and also how to approach to a migraine patient. Sir, before we start taking questions, just one query from my side. Also, few of the doctors have reiterated regarding combination prophylactics in migraine, especially chronic migraine, those comorbidities. Yeah. Am I audible?
Yes, sir, you are audible.
Yeah. So few of our doctors would like to know about combination prophylactics, especially in migraine patients, chronic migraine, those who do not have additional comorbidities. You have rightly described comorbidities where we can use combination, but those without comorbidities. Prashant, sir is not audible.
Sir, we cannot hear you. Sir, please unmute yourself. Please unmute yourself, sir.
Can you unmute, sir? Deepak, can somebody unmute, sir?
Yeah. Santosh.
Sir has to be unmute himself, sir. Nobody can unmute.
Okay.
Yeah. Sir, please unmute yourself. Okay, right. Right.
Yeah, I had to stop sharing and then come on this.
Yeah, please.
So I got your question. The question was combination treatments, prophylactic drugs. Now, in the absence of comorbidities also, there is a scope. I talked about using the therapeutic opportunities and limitations, that is with comorbidities. But in the absence of that also, there is scope for synergy based on different mechanisms of action. Generally, you start with a first-line drug, which is either a beta blocker or flunarizine. And then when you find the patient is not responding to either of those, then you can combine. Many patients would also have benefit with a small dose of amitriptyline. 5 milligram dose of amitriptyline is very helpful to avoid sedation. Increasing to 10 milligrams after 15 days or a month of amitriptyline is very helpful. But unless there is depression, please do not go beyond 10 milligrams. So therefore, a propranolol with amitriptyline. Flunarizine itself has sedative potential, so do not combine it with amitriptyline. Then when you add on the second drug, it has to be, or it is usually either a divalproex or a topiramate based on the contraindications in that particular patient. And then later on, if you wish to go for any other of the SSRIs, SNRIs, or a bigger antidepressant, then you add on to that. So along with these, you can use one of the nutraceuticals and combine it. And so that would be a combination therapy, but you need to take each one of these to their maximum dosage, allowable, tolerable, because when in Indian patients, the dosages are quite different from what you would read in the books. So therefore, do not go by just the books, go by what your patient can tolerate. Soumyadip, you can yourself add on to whatever I'm saying, because there are points which you might also...
We would actually love to hear from you. Because everybody here joining here and typing in the questions one by one, so they want to hear from you, sir. So we'll take a few questions from our doctors, young doctors who have been enthusiastically listening to you. So I'll go to the first question. Dr. Sagya Patnaik, she wants to know, she's from Cuttack, she wants to know the therapeutics, especially for chronic migraine, and how long do you use valproate or propranolol? Once you start a patient on valproate and propranolol, I think you have answered it in your talk, but they want to hear from you. How long do you use, sir?
So the duration is a very tricky issue which keeps varying from patient to patient. Now, you have to be very careful when you first start a particular drug, either divalproex or topiramate. Look at all the contraindications and then make sure that this patient is safe for that particular drug. Then when you start the drug, then you start at the lowest dose, and then through follow-up, which could be monthly, you need to titrate. I generally would like the first follow-up to be within the first 2 weeks. The subsequent follow-ups can be at the end of a month or 2 months, but the first follow-up, if it is within the first 2 weeks, you get to know a lot about whether the patient is compliant, whether the patient is tolerating the drugs, so many things about the patient's prescription which he is taking. The second thing is you need to step up the dosage at every follow-up, and you need to keep watching for any side effects that may be developing. And once you take it to the maximum dose, say for example, for divalproex, because of weight gain issues and hair loss issues, generally I find that it is very difficult to cross anything more than 500,000 milligrams in our Indian patients. Beyond 500, you find patients. Here it's important to remember that migraine patients are exquisitely more sensitive to side effects of anti-epileptic drugs than epilepsy patients. So Epileptologists might be very comfortable with 200 milligrams of topiramate in a day. But in a migraine patient with 25 to 50 milligrams, you will find that they come up with a lot of funny side effects. And the commonest sentence they use is, I was never like this before. Things have changed with my behavior, my forgetfulness, my memory. So therefore, remember that they are exquisitely more sensitive than epilepsy patients. And you build it up to the maximum dose and then continue for 2-3 months till you drop the frequency and the severity. And at the end of 3 months or 6 months, take a call and try, if the patient is comfortable and you have achieved the 50-60%, then drop it to a maintenance dose. The maintenance dose is minimum required to keep that patient well. At the end of a year or so, when the frequency drops to less than 4 per month, then you can look at coming off the prophylactics and telling the patient to take just the acute as and when required. And come the next summer, or the heat in India is more in all the places, when the frequency will go up, he can go for periodic prophylaxis for 3 months, 4 months in a year. The remaining good months, he can be off the prophylaxis also. So you have to be clever in minimizing the medication. You have to achieve the maximum with minimum medication. So therefore, there is no set rule. You need to keep changing. A lot of things depend on the level of education of the patient. Less educated patients would want more, but more educated patients, you can find it easier to manage.
Thank you, sir. I think Dr. Sagyan and Dr. Swati's question that was has been rightly answered by sir. So you have to be very careful in choosing your patients and the time. As already sir has reiterated, it needs to be individualized for each patient. We go on to the next question from Dr. Bala from Bangalore. He says that once his migraine starts, he takes some Dolo, but within hours of onset, the intensity of the attack multiplies. So what does he do when it intensifies and does not subside for 2 to 3 days?
Yeah, I would suggest that instead of just Dolo alone, go for a specific anti-migraine acute drug, either a triptan. In these days, nobody generally gives ergotamine unless the patient cannot afford a triptan. So go for one of the triptans, and amongst the triptans also, there are about 30 to 40% who might not respond so well, but if you fall within the 60% and try out the different triptans, it's not necessary that one triptan should work for all. Try out the different triptans and combine it with a tablet of naproxen and domperidone, and you will find that the combination of these two drugs works very well where Dolo alone does not work. And take it early enough. See, if you're going to take it late, you will still find that you need a second dose. So take it early enough and be watchful for any recurrence and other features. But otherwise, if Dolo does not work, move on to a triptan.
So, Dr. Bala, I think your query has been answered. So start early so that you avoid the vicious cycle. So Dr. Shruti from Delhi wants to know, sir, if migraine is side-locked.
Yes,
so
that's a good question. In about 15% of patients, migraine can be side-locked. And the dilemma when migraine is side-locked is, number one, you have to imperatively, regardless of whatever the history, you have to rule out an underlying structural lesion by doing an MRI with contrast, because things, and an MR-NG also if required, because things like vascular malformations, aneurysms can come with headache looking like migraine. That is the word migrainous is used. And that is when it is side-locked. Otherwise, the routine migraine that you see in practice generally alternate sides, but they can also be side-locked in about 15%. And when it is side-locked, and there are some autonomic features with migraine, you may tend to get confused between migraine and a TSC like cluster headache. So therefore, that is when you need to be able to differentiate from the other features that what you're dealing with is migraine with autonomic features and not a TSC, because the drugs are vastly different. In a TSC, you will use drugs like verapamil and lithium and ergotamine, whereas in migraine, you would use quite different drugs for prophylaxis. So therefore, this has to be, one has to be alert. But that is when you see a lot of migraine patients, you come across this situation.
So rightly said, sir. So only 10 to 15%. And if you have something sidelocked, many a times we have discussed this migraine cluster overlap in our conferences. So you have to be on the lookout, as sir has rightly pointed out, just in case you have some autonomic features and a male patient, especially, you have to be very careful. Dr. Rajesh from Indore, he wants to know, in spite of the best treatments available, patient resort to clombiflam or these Dynapar, NICE, and for immediate relief, Ibupara, instead of triptans. All the other routes are tried and they don't work, and they don't go for triptans. So whether it's a fault with the patients or it's the doctors who don't prescribe them.
Yes, Rajesh, your question is well taken because he generally has some of the most difficult patients coming to him. I don't know how they track him out. So he is quite right in asking this question. Number one, the triptans are costly. So therefore, patients generally stay away from using the triptans, although they may come and tell you that I do use the triptan every time. So they would like to stick to drugs like Combiflam and NSAIDs of all kinds because it is much cheaper and quite often they also work. So therefore, it is not necessary that every patient should go in for a costly triptan. And that is one. The second is patients are non-compliant and they are not on background prophylactics on a daily basis. And so therefore they find that many a times their triptans may not work. So that is another loophole you have to block. The last is the patients have always come and tell you that humne bahut dukaan dhunda, I could not find the drug that you have prescribed. So therefore they do not go beyond one triptan. So it is necessary, a person who has not responded to sumatriptan or rizatriptan may respond to almotriptan or elatriptan. Now elatriptan is so difficult to get, so the patient does not, naratriptan is not available at all. So the patient does not search in different chemists and therefore he is quite often, it's a question of compliance. And if you make sure that your patient gets the drug, comes and shows it to you and choose different triptans, and give it at the highest dose, then you'll find most of the patients respond to the drugs. So the patient going in for an NSAID on his own is the patient's fault, not the doctor's fault. The doctor prescribes something else, the patient takes something else. So the point is well taken.
Thank you, sir. And last question for the evening. We have Dr. Sanat asking whether some Uttarpara and Hooghly foods in migraine. He's from Hooghly. Oh, sorry. He's from Hooghly. He wants to know foods which needs to be avoided in migraine.
Yes.
Right.
Now, many of these food items, fortunately, dietary triggers are not so common. And when you do encounter them, it is generally the fermented foods which can cause migraine. The absence of breakfast in the patients not having a breakfast habit is a big reason why. Otherwise, it's the fermented foods, a lot of things which are not consumed so commonly like chocolate, cheese, red wine, and the aspartame, monosodium glutamate in Chinese food. These are all not so commonly consumed. But these can also be food triggers. In our country, the most common is the fermented foods, which are like idli, dosa, and dokla and other things, which can give rise to some patients' migraines being triggered off. Otherwise, cold items, sometimes ice cream taken too fast, most of the alcoholic drinks would also give rise to headaches, which could provoke in a migrainer, predisposed migrainer. So food triggers are definitely to be taken into account, but that need not be the be all and end all of migraine treatment. That is just one small component which you need to alert the patient about. But people tend to go to Google and think that that is the only treatment for migraine. They forget that there is a lot of other things which they can take for migraine.
So very rightly said, sir. So foods need to be taken, but it's not all. And sir, before one question from my side before we end, many a times we see cases which are overlap of migraine and TTH in the busy OPD. So it becomes very difficult actually which drugs you are going to prescribe. Sometimes they come with characteristics of migraine attacks. Sometimes they come which fit into TTH. You are an authority on these overlaps, especially migraine cluster and even migraine TTH. So how do these young doctors proceed to approach these cases?
Yes, good one. So by and large, tension type headache is a featureless headache without any of the accompaniments of migraine. But as you have rightly said, when it is mild migraine, it can look like tension type headache or TTH. So in my experience, patients with tension type headache tend to self-treat themselves with over-the-counter products. They rarely end up in a doctor's clinic for consultation. And because the headache is less than 3 to 4 by 10 in intensity, and they can manage it with pain balms and paracetamol or something like that. Now, when they do come to the clinic, you need to first see whether there are any accompanying features. Some of them can have photophobia, phonophobia. In that case, they are to be treated like migraine. A lot of them respond with just 5 milligrams of amitriptyline. And sometimes you need to use simple analgesics, but do not go with the triptans to treat those borderline patients. Even if it is mild migraine, you could use one prophylactic, and sometimes what looks like tension type headache might respond to your prophylactic, in which case retrospectively you come to know that it is mild migraine actually. Go for the family history, go for the surrounds of migraine. See, migraine is a diagnosis to be made by inclusion, not by exclusion. So you need to find features which fit into the criteria, the diagnosis, and your suspicion must be based on some serious clue. Your suspicion must have some criterion to call it migraine. And the overlaps are not so often, but because tension type headache does not come into the headache clinic, you should diagnose most of your patients with migraine, even if they don't have all the features. And migraine and TSC, the overlap is not so difficult. You've already told about it, so it's not difficult. It's a male patient who comes with side-locked headache.
Right. So one last question. Preferred drugs for childhood migraine prophylaxis, asked by Dr. Pitambar Beuria from Cuttack. Which drugs would you prefer for a child with migraine?
If the child is below 10 years of age, I would prefer cyproheptadine. Give a small dose of cybalium, and I would definitely add a nutraceuticals. And if the child is above 10, then I would, and the migraine is difficult to treat, then I would think of adding an anti-epileptic drug along with beta blockers if required, depending on the severity. But I would go first with beta blockers and then add an anti-epileptic divalproex. There are studies to indicate that topiramate has got a very big role to play in the childhood migraine. And now that we have evidence for magnesium as a big role in pediatric migraine, so it could be forming a constant part of every prescription for pediatric migraine.
So, and last is experience on nasal triptans. He has another question, experience on nasal triptans. So,
yeah, the triptan nasal spray, there's only one available to us, zolmitriptan. Earlier, for a short time, sumatriptan was also available as a nasal spray. Now that is no longer available except one small company. They don't distribute it too well. So now the nasal sprays are useful in two situations. One is where the patient is vomiting, and two is where you want speed of action. So the fastest way to give a triptan is by injection. The next is through a nasal spray, and the last is through the orally disintegrating wafers. So nasal spray, when you want speed of action, the patient is never satisfied when you give it through a nasal spray because he doesn't feel that there is a drug which has gone in and there is a bitter taste to the whole thing. So the position in which the patient takes the nasal spray has to be perfect in order to but now after the swabs test for COVID-19, everybody has become an expert at everything being inserted into the nose in the right way. So nasal sprays are helpful in a situation where you need it rapidly.
So last thing before we wind up, do we have a surge of TTH patients in this COVID era?
Yes, definitely yes. And because stress, as you know, is a trigger for migraine. So we also have a number of migraineurs coming back to us for follow-up more easily. A number of patients with stress-induced tension type headache, where they feel that all is not well because there is universal depression at the moment. So there is not a single person who is happy because of the lockdown. So there is a lot of stress-induced tension type headache is definitely more these days.
Thank you, sir, for taking so much of pain and taking all the questions. And now I would like to thank sir for this wonderful lecture and session. And over to you, Deepak, for whatever closing and.
Thank you, Soumyadarshan, for conducting it so well. Thank you for being a.
Thank you, sir.
Dear doctor, thank you very much for joining us. We conducted this webinar to observe Migraine Awareness Week, which is on from 6th September to 12th of September. And we had this wonderful lecture by Sir Dr. K. Ravishankar, a relook at migraine prevention treatment. And really we had a relook because he defined the migraine as chronic disorder with episodic attacks. And that defines the treatment. The treatment is long-term and chronic. And that is very, very important take from this webinar. And patients are suffering and patients need to be looked at in a very empathetic manner. So, sir, thank you very much for this wonderful insights on migraine and looking at migraine from a holistic point of view and also giving nutraceutical support as a treatment. I would like to thank our moderator, Dr. Soumyadarshan Nayak, for coordinating this session extremely well and taking the questions, and Dr. Ravishankar sir for giving a new outlook to migraine treatment, very, very apt in this Migraine Awareness Week. Thank you very much, sir. You are like a Bhishma Pitamaha in migraine treatment in today, and today yours is the last word. Thank you very much for your support and this wonderful lecture. We really enjoyed it. This is Deepak Naik on behalf of Health and You signing off and thanking all the doctors, requesting you to support Health and You products. Thank you so much.
All the members in the audience, we can't see you, but we can definitely say thank you.
Thank you, sir. Thank you so much.